The problem in Rwanda and throughout most of the world is that medical care providers tend to provide a quality of care below their capabilities. So what we find is that many providers are well trained, but the actual standard of quality they provide when patients come through the door is well below that. So a major question has become, how can we improve quality of care and health outcomes without investing massive amounts of money? Instead of investing more, we can try and get more out of our existing resources. And the idea is to use financial incentives to see if they'll do more of what they know. And that led to this body of work called Pay for Performance in Medical Care. There's something called clinical practice guidelines, which are what the clinical science says and common wisdom amongst providers of the content when someone comes in for a clinical visit, so the tests and advice and treatment patterns that should be applied to maximize outcomes. And in Rwanda, we compared actual practice to the Rwandan clinical practice guidelines for prenatal care, and we found that when you provided financial incentives, the quality of care went up by 30%. There was an increase of 30% with the compliance of guidelines, and that led to substantially healthier kids as measured by their height and weight. So there are two types of things. There's a base salary or base payment that every clinic gets, and these were bonuses on top of that. So the government had decided to put more money into the healthcare system, so this was an opportunity. Rather than just increasing their base salaries and their traditional input budgets, we said, okay, what we're going to do is we're going to say, if you see more patients and you provide them a higher quality of care as benchmarked against these clinical practice guidelines, you'll make more money. And in the end, this led to about a 22% increase in the amount of money going to these facilities based on performance, of which 75% was used to give people bonuses based on performances for clinical care. But one of the nice pieces of this research is it wasn't our intervention. This was an intervention by the Rwandan government. And we worked with them and did an evaluation with the national rollout of the procedures that they designed with experts from around the world. What the Rwandans did was they established a set of indicators. Those indicators were number of prenatal care visits, the clinical content during the prenatal care visit, the postnatal care, the clinical content during the postnatal care. They established these indicators. And then for a large number of these, they asked the providers to report how many of them they had per month or per quarter. And then they did random audits to make sure that there wasn't any cheating. And the audits were of two forms. One was they went to the clinics and make sure they had the paper backup. But then they took a sample of those bills and then they called patients and asked, Mrs. Basinga, it said here that you at this clinic that you went for a prenatal care visit and they gave you a tetanus toxoid shot, and she would respond, yeah, I remember going there and I got some sort of shot. And so they validated the bills against the payments through audits. The Rwandan government embedded these financial incentives, these bonuses, in their national budget for healthcare. And that's typically the way it would have to work. And what they argue is it's cheaper for us to provide these financial incentives than to build a whole bunch of new healthcare clinics, to hire many more doctors and have to pay for their salaries on an ongoing basis. We talk in the US about making Medicare and the federal government more efficient through reducing fraud and abuse. Well, another is to provide incentives, and so we get more with the existing infrastructure. One of the nice things about the Affordable Care Act of the United States, or Obamacare as it's become known, is one of the central features is to start to use financial incentives to improve performance. And so if we're going to make progress on reducing costs of Medicare and Medicaid, the two large social safety net healthcare programs we have in the United States, public ones, using things like financial incentives is something that can really, really improve care, make it more efficient and improve the quality of care dramatically. I don't think of these bonus payments as adding money to the system. I think of it as getting more out of how much we're already paying. These types of incentives are very common in the private sector in the United States. Most or a large number of managed care insurance companies give small increases to the capitation rates for performance. Things like share of your patients, female patients who've had pap smears or immunization of children or things like that. The limitation in the United States, I don't think, is acceptance. I think the issue is our information and data systems are much more complex. We've had every insurance company has a different database and requires providers to report in a different way. Oh, you talk to anyone and they say, I think if you want a merit-based system in the world, that people who do better get paid more. That's what's happening in Rwanda, and we have a healthcare workforce which is doing good work, and they're rewarded for it. So this model is being tried throughout Africa, Latin America, and Asia right now, so it's really being scaled up.